Hi, everyone. My name is Viet. Thanks for joining me for this talk. I'm going to talk about lower extremity return to sports testing today. A little about me is after I finished PT school, I went to a sports residency at Gunderson Health in Wisconsin, and then I completed a Division I fellowship over at Wake Forest University. Currently, I am the physical therapist for Stanford Athletics. I'm a part of a team of 5 PTs here. And then I am also associate faculty at Tufts University, and I also do some consulting on the side as well. Some disclosures is that I am a product evaluator and tester from Simply Faster, but no technologies mentioned today are sold by them. Today's objectives is to talk about a checklist of important things to test and why. Unfortunately, due to time, we will not have the time to go over interventions to achieve such goals. Luckily, if you're a sports section member, you can go on the website sportspt.org, I believe, and you can have access to a lot of videos, and a majority of them are free to members as well. So this is a very popular topic that comes out and is well attended at a lot of webinars and also conferences, because you can see here that as times change, so does our decisions on what's important. The hard part is within those categories, there's also more nuances and tests that kind of spring up every now and then. So it's hard to keep up with it. So that's why it's so popular. Current practices show that not all patients get tested adequately. I'm going to talk a lot about ACLs today, just because that's a lot of where the research is at, but I'll certainly hit other body regions. But Allison Toole found that only 53% of patients pass their HOP test when they're discharged from PT. Only 28% pass their strength test. And then as a whole cluster, only 14% pass their return to sports cluster at discharge after ACL reconstruction. Does it matter? Well, absolutely, because those who actually passed the cutoff, a larger proportion of them went back to their prior level. And we always hear about that 30% reinjury rate or the 50% return to play rate. Dr. Arundel, what she did was she looked at a 2-year follow-up of elite soccer players, about 40 of them, and a small size, but all of those who were injured did return to 100% return to sport, 95% return to play, 2.5% injured. Got injured again. And then in 2016, Grindam et al. Looked at, had a prospective study as well, looking over a 2-year course. But you can see those who passed the full criteria, which is similar to Toole's cluster and Dr. Arendel's cluster, about 40% ended up re-injuring themselves who did not pass, whereas if you did pass, it was about a 6% re-injury risk. Well, what if there's injuries out there that's just not sufficient to show that you can prevent injuries? It's still important from a performance side and just from being a human being again. I mean, you're restoring the athlete to prior level. So you could look at this through limb symmetry index, and you could also do allometric scaling. So this is comparable to their strength to their height or their limb length, whatever it may be, but relating it back to their own proportions. And then more than anything, if they are going to compete again, you want to make sure they're normalized to their comparable athletes or their competition. Are they ready to go back if they're going to compete? And nowadays, there's more and more normative data in specific sports and specific age groups. So you have a lot of data to work with, see if your athlete's prepared. So my advice to everyone is use a very systematic checklist, and your checklist might look different from mine, but this is what I look at. I look at pain, joint effusion, range of motion, strength, functional test, time, and patient-reported outcome measure. Those first 4 are probably be the most important to me because they really are going to set up the later phase. If you don't take care of the first 4, you're probably not going to have a good time with those last 3. So first we talk about pain, and pain's important because it affects strength. And as many of us know, strength is very important in return to sport. But you could see here, the painful group, they had some injections straight into their patellar fat pad. And what they found was in the group that was effused, painful, had significantly lower force production from their quadricep. For the hip, this is kind of like a 5-second squeeze test, basically. They're squeezing as hard as they can. They report their groin pain 0 to 2, or a 0 out of 10. And you can see here that first group, which hovers around 0 to 2, they had a lot more adduction strength too. So pain can affect adduction strength there. And then a lot of it, I like putting this one up because we say, well, maybe it's just the nature of the structure sometimes. So like, let's say ACL injuries, it was a bone patellar bone graft. So maybe it's just a surgery that hurts it more. Well, in this study, they looked at 600 people who had hamstring graft and 600 who looked at bone patellar bone. And what they found at 3 months and 18 months is it was the same rate that had anterior knee pain. So really, it's probably our fault. We need to control this, whether it be management of exercises, assistance from medication, or any other modalities that might help. I think it's important that we take care of this early so that it doesn't affect later rehab. Next is joint effusion, the most popular way for the knees to look at sweep test, which has been shown to have good reliability. And most of you guys have learned this in PT school already. For the ankle, you can look at figure 8. So you're just comparing side to side circumference. And you can also do measurements for the knee as well. The joint line measurements might be swelling, and then you could also go maybe a few centimeters above just to see if there's any swelling that protruded to the suprapatellar region of the joint capsule. And then you could also get quad girth, calf girth too. So those aren't effusion related, but those you can kind of knock out 2 birds with 1 stone there. For the hip, I don't have any good measurement methods that way. But effusion is also important. Going back to that study we looked at earlier, again, the fused, when they're effused and painful, basically this was looked at when they injected 60 milliliters of saline into the knee joint, force production was decreased. In addition, it required higher activity to get the muscle response moving and the muscle out of rest. So this quad activation, it was also decreased in those who were injected with 50 milliliters. So again, we don't want to do the patient bad. We don't want to, we have to kind of manage the loads and manage the rehab and not progress too far if swelling is just persistent there. We have to be just patient with it early on. And then your later stage rehab will go really fast at your patient during the early stages. Next up is range of motion. So also very important. Everyone knows that we want equal extension, but like, where did that come from? So this study from Dr. Shelbourne looked at patient follow-ups of 10 years later. Basically what they looked at was their knee range of motion. And basically this was ACL reconstructed patients. Basically, if you had less than 2 degrees extension loss, you had a significantly higher patient-reported outcome measure, as well as the symmetry index compared to a greater than 3 degree extension. So some people say within 5 degrees, but I try to get it as straight as possible, equal to the other side, because it does make an impact later on. And then what about patellar mobilization as well? So this is important because you could have joint adhesions, basically in multiple areas of the knee. Most popular is the suprapatellar region and also cyclops lesion. So what they did in this one was a cadaveric study, and they attached the anchors and pull forces to simulate that of the quad. And then to simulate what adhesions would do biomechanically to the knee joint, was they anchored it at the top to simulate a suprapatellar region adhesion. They also did a separate anchor at the bottom for the cyclops lesion. And then they also had both to see what would happen if you had adhesions on both sides. And what they did was they just extended the knee and bent it to see patellar contact forces. And you can see here compared to the pink bar, which is no adhesions, across all different adhesions, it rises. Of course, with our theory, combined adhesions, the patellofemoral contact forces increases the most there. And this is important because that can relate to pain. So you can see that we want to be very mobile with the patella and constantly mobilize it, because we could potentially avoid it there. So I'm not saying you're going to avoid adhesions that way, but it doesn't hurt. It takes a few minutes of our time during treatment, during the rest periods. I think it's important that we hit this early on. And then next, my big 4 of the list is again, this can be strength. So it's isokinetic dynamometers are the gold standard. They're not functional, but they do have to identify the weak link. So what part of the body is causing deficiencies in functional patterns? Besides that, it's excellent training utility. You can do eccentrics, isometrics, you can do a bunch of stuff with it. The cons is it's very expensive, and if you're not experienced with it, it can take quite a bit of your setup time, but you can get it down to testing someone out within 10 minutes, both sides, depending on your protocol too. But generally with strength testing, you can look at limb symmetry index, you can look at unilateral ratios, so that'd be like ham quad ratio of the same leg. You can look at peak torque to body weight, you can look at total work, you can look at fatigue ratio. It gives you a lot of data that you can help you with.
Oh.
So here's a video of the knee. You want to make sure you motivate them as much as they can. This one you can even put an extension block for surgeons who are nervous about shear forces to the top. And then you can even do it for the ankle. You can do it for all joints, but I mainly, for the lower extremity, I mainly just do it for the ankle and the knee. If you don't have access to that, handheld dynamometers are a good option. And basically, the main thing is you want to belt fix. You're going to have a more accurate reading that way. And then you want to make sure you really motivate them verbally to push as hard as they can. The pros is that it's objective. Basically, manual muscle test severely underestimates, and it's just not a good way to compare. It's not objective at all. It's purely subjective in my eyes. And then it's a lot cheaper than isokinetics. Doesn't give you the same data, but it is an objective option that's more cost friendly. Go from $30 to $1,400, and it's relatively quick and easy. Although some people, again, in the hands of someone inexperienced, it might take them just as long to set up than an isokinetics machine. Like I said, the cons is just accuracy wise. There's so many out there. I recommend just going to this website and just comparing everything. There's prices and all that stuff you need on this website. For handheld dynamometry, hip strength is moderate reliability good. So you can see the pictures at the top. So basically supine abduction and adduction, and then prone ER, IR, and seated ER and IR without belt fixation actually has good reliability. So that's what I do, just because if I were to use my isokinetics to set up all those different ones, it'd take way too long, whereas I could quickly get them assessed with just rolling over once. And then if you have it fixated, so you see the elbow against the wall, good to excellent reliability turns to, reliability turns to good to excellent with external fixation. And this is both for peak force and rate of force development, just because some dynamometers have the capability to measure that. For the quad, it's been shown to be good to excellent reliability, especially with the belt fixation. So you could either have a push one or a pull method set up. Hamstrings, I have no clue on reliability. I didn't find any studies, but this is my way of fixation. So I'll just put the dynamometer right on the edge of that folded part, and I'll tell them push down as hard as they can. The only downside is you're unable to look at, or you're not unable, but it's kind of not a good way to look at ham quad ratio if you're interested in that, because they're in two different positions. So that nuance might cause quite a big effect on strength, although I haven't studied it. If you don't have weights, or you don't have any of that for the knee, at least you could do a knee extension to 45 degrees. Basically, this paper in 2017 says that if you are 105% equal using a knee extension at 45 degrees or a handheld dynamometry isometric, there's a 90% chance you are 90% equal on isokinetics machine. So in short, just try to get, if you're testing any other method besides isokinetics, try to get them above 100%. Full range of motion, I don't think works, because I think people underestimate how strong they are, whereas 45 degrees, you really give max effort because you're not expecting to go all the way up. And then for the ankle, it's just really bad. The ankle is so strong and such a mobile joint. The foot's has several mobile joints. So it was really poor, actually, and poor reliability. There are methods of fixation, but this method was not validated to isokinetics. It was just reliable to each other. And also, no one's going to buy that contraption and then take time to set it up just for calf strength measurement. This is the setup I use. I think this is Scott Morrison's setup where I first saw it, but I couldn't find it on his website, or a clear picture of it on his website. So this is what I put. But basically, you have a strap under a step, and then I anchor that step with my foot, and then they're going to go push up at mid-range. This person did at end range, and then you would just switch to the other side. There are apps available. So this one is called Calf Raise. It's an Apple app. It's not on Android. But basically, you're just going to track it, and then you go up, you put in their weight, and what it does is it calculates several things. So it'll calculate power, it'll give you work, it'll give you reps, it'll give you total height, and it'll give you like fatigue ratio. So from the start to the end, how much of a drop off did you have? Something you can do too is you can actually look at the quality of it, because it paints its picture. This is a posterior view. And you might say that the left foot of this individual might have like posterior tibialis issues, just because you could see it's a bigger painting and it deviates more laterally at the top. If you are doing this though, you just want to make sure that you keep the camera at the exact same spot and their foot the exact same spot when you film it, just so it can be comparable. But I would say use as a minimum of screening only. Just an N of 1, I basically had a patient show up. We did this. She actually was completely equal both sides. And then I had her test the next on isokinetics, and across 3 different speeds, there was a 30% plantar flexion weakness. So it may not be a good indicator of strength, but it may give you an indication of endurance or power and work with low loads. But what are you looking for strength? So for the hip, we want to make sure that there's good adduction to abduction ratio. So I go for both symmetry index as well as this. But basically, in a study in 2001 looking at hockey players, they found that this is a prospective study as well. Less than 80% ratio equal to 7 times risk for groin injury in season. The quad has overwhelming support. So basically, for a 1% increase in quad LSI, that will decrease your chances of early onset OA within 5 years by 4%. And then for 1% decrease in quad LSI, that's a 3% re-injury risk in ACL injured athletes as well. And then in a scoping review, what they found was relative risk was that quad LSI significantly, a good quad LSI significantly decreased the risk, a relative risk of having a re-injury. What about for the ankle? So this is called the ISS, the isometric strength scale. So this author kind of made it as a global ankle strengthening. Basically, there's 6 tests. So there's 3 different speeds, 2 motions, and isokinetics. And basically, this is their scoring system. Basically, they said that 102 is the maximum scoring with the highest score possible. From their analysis, they found that for every 16-point increase, there's an 8.3 times odds of returning prior level function, or a 6.3 chance of at least returning within 1 technical activity scale level. What I did some math, and basically if you're 90% even, you're at 78 points and you still have time to go. So with this one, I'd probably want it to be 100% even side to side if you were to do that. So we know strength is important, but you have to measure it. Do whatever it takes to get funding or buy it yourself, but it is important because unfortunately we know all the evidence for quads for ACLs, but you can see here that only 80% of PT strength tests, so 20% are just saying whatever. And this is actually from people who are members of the orthopedic and sports section. So what we consider people who are making an effort to stay up to date. And 56% of those people only use manual muscle tests. So that's not good because you know how inaccurate it is. So make sure you test the muscles. You never know what's being hidden inside. This one is going to be a kind of a big topic, functional testing. Basically, the ones you're most familiar with are cluster of 4. Really, you only have to do 2. I don't think there's anything useful with more than 2, and you can choose which ones. But basically, Hegedus 2015 found that they were not predictive at all 1 year out from injury. It didn't predict patient-reported outcome measure, and it did not predict re-injury rate. The reason they're not predictive is in this 2006 study, you can see here that if you look at square hop tests, up to 30% of healthy people can even pass it. And on the other hand, if you look at all the hop tests, about 30 to 50% or 30 to 60% of ACL injured and reconstructed people were able to pass it. So 1 in 2 people could pass it, even though they're part of the injured group. So you can't really tell the injured limb on some people, and it doesn't have a good threshold. And this recently came out. After 8 months, what they did was they test hop test, and everyone passed symmetry wise on hop test. You can see when they measured quad strength with isokinetics, there's still a 30% difference in quad strength. So again, it's masking quite a bit. And it might just be the test itself, right? So what might be better, a horizontal or vertical? Well, it depends on what you're testing. So this study looked at contributions of joint forces. And basically, vertical distance may tell you more about quads than horizontal. As you can see from the horizontal propulsion side, the horizontal hop uses more quad, the horizontal uses less quad compared to the vertical. Saying that though, vertical hop you can see from both push and landing, it's 30% for all categories. So it might be better than the horizontal, but it shouldn't replace isolated quad strengthening, because all joints can be given equal. So it's certainly better than the horizontal for distinction quad, but it's not the end all be all either. And then for horizontal distance, it might be useful because we know it relies more, I'd say not so much, but more on the glutes. So you might want to use it for a hip injury. So they all each have their uses. You just want to be specific about it. And then drop vertical jump. These were very well done studies, good sample size, looking at good support for predictive factors, looking at biomechanics of the drop jump landing. But the downside is it takes a whole lab, takes a 3D camera system, some force plates. So I don't think it's clinically available yet. Shameless plug though is our lab mates over at the Stanford Neuromuscular Biomechanics Lab. They're doing some great work. They developed a program where you just take two iPhones, you set it 45 degrees, and you can add more phones if you want, but point of diminishing returns is two phones, and you can look at different movements. And they actually found about 94% accuracy when comparing to other camera systems and force plates. And then 97%, they can detect like any changes you've done where it's like your weight shifting more towards a squat. So they are publishing, it's in review right now, their validation study on this with a sample size of 100 athletes. And there is a preliminary study out with a sample size of 10, but you can contact the researchers there. They'll tell you more about their validations and how they came to be. But it's been really cool seeing them develop this and when they gave us a hands-on trial of it. So technology is coming there to be more clinically applicable, but it's just not quite there yet. And the reason why you would probably need a camera system is this study looked at it basically 240 practitioners of all disciplines with a varied experience with athletes and experience in the field. They'd watched some videos. Of those videos, 20 had ACL injuries. They're at a rate of 0 to 10. How high were these individuals likely to get ACL injuries? Well, the funny thing is in the injured group, the average rating was 4.5, and then the average rating for the non-injured group, performance jump, was 4.8. So this tells you that you're probably not as good as you think you are at detecting such changes and seeing who's at risk and who's not. But again, there's a time and place for it. So Dr. Kivlin tried to look at different tests for the hips. So you want to just do like knee tests for the hip, it would be different. And he developed a test or a validation, or not validation, but reliability study for lateral hop test and medial hop test, and then a crossover hop test for time. And you can see here that really it was just a medial hop test that had a difference. The only downside of that though was it was statistically significant, but it was only a 5% difference. So I do use this test for hips specifically, but I want 100% or better. And then for the ankle, a lot of people use the star excursion balance test, but it has quite a low ceiling. So this study looked at the dynamically balanced test. So they're going to jump forward, back, and then medially in those directions. So it's to 1 and then back to center, to 2, back to center. Each time they get to the center, it's about a 2-second hold. And basically you're timing them. And what they found in this study was between those who had chronic ankle instability, they could detect which limb was injured. And they also compared this to the star excursion balance. And in this study, the star excursion balance could not detect the injured limb, whereas this test could. So the benefits is it's a higher ceiling than star excursion balance. There's good to excellent reliability. It just takes longer to set up, if not the same than star excursion balance. And in this study, the practitioners weren't blinded as well. The next important thing is going to be patient-reported outcome measures. So you have different ones for each region. These are important because you can get them as strong as they want, but what about returning to sport? So Dr. Webster in 2022 released a study, What Tests Matter? And it wasn't actually the quad strength or a functional test that got a person back to playing their sport, but it was actually their perceived disability. So she found that a greater than 85% on the AKDC was a 2.4 odds of returning, not re-injury, but returning. For the ACL RSI, it was greater than 65%, had a 4 times likelihood of returning. And then Warner in 2021 found that people with 80% were more likely to return to performance and lower scores. And you can see here, going back to what we talked about in front, you can see how pain is such a huge driver of the Hagel score. So again, The green is those who scored 0 to 2, and the Hagel score is there. So again, if you don't take care of it early, not only are you going to encounter strength, but what if that person just doesn't come back from the sport? They could be as great as they want, but just their confidence isn't there. So you want to make sure you take these measures. Tampa scale 11 is also an option. Basically, you want to score greater than 17, lower than 17, and certainly lower than 19, because the risk of re-injury after ACL injury reconstruction is very high there. But yeah, 50% of athletes don't return due to fear. This is based off the study of the ACL, several studies, not just the ACL RSI. Those who were injured had no significant change from their pre-op. So this was McPherson's study, or I believe it was McPherson's study, but basically what they looked at was they took baseline ACL RSI before pre-operation, so it is important to take. And they found that those who actually returned to their sport had about a 15-point increase versus those that did not return to sport had next to no change at all on the ACL RSI. So it's still useful to get baseline as well, pre-operation. And in the literature, the score seems to be somewhat of a moving target. Some report as high as 77. I like 77 if that's the highest. But again, that Webster showed that 65% was good, but that's what I do. I use 77%. And they're not perfect, right? The recent commentary came out talking about limitations of them. But the good thing is if you put work into looking at them, you can choose the right one appropriate for that athlete that will answer what is valuable to that athlete. So although there's nuance to it and people have their complaints about it, I still think it takes zero effort to administer with all the research that's out there on each of these. Just choose one of these ones for each body region, and you'll be doing better than most in ensuring your athletes are getting back to sport. Don't give too much though, because survey fatigue is real. You don't want to have them sitting there for half an hour taking surveys. And then the last thing you want to check off is time. So this is a common argument that comes out. You hear it all the time. Re-injury rate reduced by 51% for each month. Return to sport was delayed until 9 months in ACL reconstructed patients. Maybe not, you don't see the link to it right now, but a recent article came out. It got a lot of news because it said that prior to 6 months, basically the higher quad index you have, the more at risk you are at injuring yourself. But if you look at their data, this is the exact data that we looked at earlier. Look at their data. For those who looked at before and after 8 months, they were next to nearly equal with functional strength and quad symmetry. The group that returned 8 months after did not have a high re-injury rate. So the only that's different really was time. So this wasn't a quad symmetry issue, it was a time issue. So statistically, they just reported what they found. So they're not in the wrong for that. But when we look at the clinical contextual factors of this is most likely a time issue. And that's what they found. They said time for every month that returns to activity or that was delayed, every month that was returned to activity was delayed results in a reduced risk of injury by about 30%. So you don't want to let them out too soon, because bad things happen when when athletes are released too early. So again, this is a checklist, and these are the criteria you want to see. Obviously, there's a handout in the link to this video in the description area, but I've also put it in the chat. Just to make it easier too, here's a minimum return to pass criteria. For the hip, you can look at these values. For the knee, you can look at these values. And for the ankle, you can look at these values. The main point is that for each region, you want to be very specific to what the research says for that region. You don't want to do a knee cluster for a hip cluster or ankle cluster. You want to make sure that the research supports each body region for that one. Here are my references. And I wanted to thank you all so much for reviewing it. And I hope you guys have a lot of questions that I can answer. I'm happy to talk, and then you can also email me as well or drop a comment in the video that's posted after, and I will happily answer all these questions for you. So again, thanks again, and I hope you guys all have a great evening.